तो काही इश्यू नाही आहे. दे आर व्हेरी गुड. आणि अगोदर सुरुवात त्यांनी केली. काय होतं सांगतेस आणि हे असं तुझं फक्त लॉजिंग ती लॉजिंग त्यांना आता काय केलं फक्त रेट्स वाढवून फिल्टर केलं. फक्त गुड क्लास ऑफ फॅमिली ठेवतो आणि कॉलेजची वगैरे डान्स घालायचे त्याला मी एकदा दोनदा सांगितलं आम्ही जेव्हा ऑड वाटलं ते पण जाऊ द्या म्हटलं
Party with separate came to the University Medical College and Hospital Sangli, and the case will be presented by Dr. Rakesh, who is junior resident, along with Dr. Niharika, who is senior resident and mentor, will be Dr. Sara Madam. So I will hand it over to Dr. Rakesh for his
Thank you, sir. Good evening, everyone. Today I will be presenting a rare case which post diagnostic and management dilemma. So, a 5 years 6 months old female child, second issue of third degree consanguineous marriage, brought with a history of 3 episodes of pneumonia since the age of 4 years, was brought with the complaints of bloody diarrhea on and off for 6 months, which increased for the past 2 months, abdominal distension for 2 months, and fever for 14 days and vomiting for 8 days. Since the child started being symptomatic from the 4 months of age, I would like to start the history from the same. So child was well till 4 years of the age when she had 1 episode of pneumonia, which was treated on the OPD basis. At 4 years 3 months of age, child was admitted in view of pneumonia for 5 days. Again, at the age of 4 years 6 months, child had 1 more episode of pneumonia, for which the child required hospitalization for 5 days. Child was symptom free in between the admissions. At 4 years 7 months of age, child was referred to the KEM Hospital Pune for the further workup, where she was extensively investigated and in view of suspected immunodeficiency disorder, immunological workup was done. The following investigations were done in the KEM Pune: lymphocyte subset assay, immunological profile, and NBT, which were normal, and the diagnosis at the time of admission was recurrent pneumonia with anemia, vitamin B12 deficiency, severe acute malnutrition. B12 level at the time of admission was 100 picogram per milliliter, and child required 1 transfusion for anemia. 3 months later, at 5 years of age, child developed a new symptom in form of bloody diarrhea, 5 to 6 times in a day, non-foul smelling, small volume, associated with mucus, and without any aggravating or relieving factors. Child was investigated again in KEM Pune and was found to have severe anemia. HB was 3.9, DCT was positive, and retic count was 3.5%. For this the child received 2 PCV transfusions over there, and bone marrow was done, which showed mildly diminished megakaryocytes. Child also underwent the lower GI endoscopy, which showed inflammatory bowel disease with stricture and large sigmoid polyp. Biopsy done at the KM was inconclusive, and the other investigations like PET scan and fecal elastase was done, which was said to be normal, and DNA gene sequencing was sent at the time of admission. This was found to have the immunodeficiency 30, and the peripheral smear at the time of admission was microcytic, hypochromic anisocytosis with pencil cells. WBC showed neutrophilic leukocytosis. At this time of admission, steroids were started, but the patient was not compliant with the medication. At 5 years 2 months of age, child was admitted for 7 days in view of fever and enlarged cervical lymph nodes, diagnosed as cold abscess at KEM Pune. Excisional submandibular lymph node biopsy was done. This revealed the hemophagocytosis with extensive karyohexis with no granuloma or caseous necrosis on the histopathology. Pus and lymph node biopsy were sent for gene expert, which came negative, and TB gold was done, which was negative. Child continued to have intermittent episodes of bloody diarrhea. At 5 years 4 months of age, colonoscopy with biopsy was done, and biopsy revealed colitis with colonic stricture, query Crohn's, query tuberculosis. Prednisolone and mesalamine was started and continued till the presentation to our hospital. Almost for the 1 month, child has taken this medication, but there was no improvement in the symptoms. Biopsy from the colon showed chronic colitis with moderate activity and ulceration, favoring the inflammatory bowel disease. There was no granulomas and no evidence of CMV or dysplasia. At our hospital, child has bloody diarrhea 5 to 6 times in a day, non-foul smelling, small volume, associated with mucus and without any aggravating or relieving factors. Child also has an abdominal distension for the last 2 months. Child was having fever for 14 days, which was intermittent, 2 to 4 spikes per day, high grade, without any diurnal variation, not associated with chills or rigors, and temporarily relieved on medication. Child was also having vomiting for 8 days, which was non-bilious, non-projectile, non-bloodstream, containing food particles. So, coming to the birth history, child was a full-term born by LSCS in view of gestational diabetes mellitus and bad obstetric history. Birth weight of the child was 3.5 kg and cried immediately after birth. There was history of NICU admission for 10 days in view of infant of diabetic mother and acyanotic congenital heart disease. PDA and ASD were there, which were closed later. Child is immunized till 2.5 years of age as per the national immunization schedule, and there was no any history of developmental delay, and child was belonging to the lower middle class as per the modified Kupus classification. So based on the history, analysis of the case was, this was a chronic disease process with the history of recurrent infections suggesting a primary immunodeficiency and with the features of autoimmune manifestations, as the child has a Coombs test positive hemolytic anemia and chronic bloody diarrhea, which would be possibly due to inflammatory bowel disease or tuberculosis, and also severe growth failure. On examination, anthropometry, child was having the chronic malnutrition with severe wasting and moderate stunting. So this was the image of the child before the onset of the disease, and this was the image of the child after the onset of the disease. This was at the 4 years of age, and this was at the presentation to our hospital. So based on the previous records, we have constructed the growth chart. So it was showing the growth faltering at the age of 4 years, which was coinciding with the first admission of the patient. So coming to the general examination, child was on admission, child was sick looking, cachexic and lethargic. Child had severe pallor, facial puffiness, bilateral pitting pedal edema, sunken eyes, oral cheilitis, oral thrush and angular stomatitis. Child had grade 2 clubbing, and child was febrile with 1 or 2 degree Fahrenheit temperature. Heart rate was 146, RR was 40, and BP was 90 by 48 millimeter of mercury, which is 58 to 98 centile, and saturation was 99% on O2 bronchs. Pulses were well filled and extremities were warm with a CRT of less than 3 seconds. And child was having cervical lymph nodes, which were palpable, largest of the size of 1.5 to 2 centimeters at left jugulo-digastric region, which were firm in consistency, matted with irregular margins. Axillary and inguinal lymph nodes were also prominent. On systemic examination, abdomen was distended with stretched umbilicus. Heart mass was palpable from the right hypochondrium extending into the right side of umbilicus with irregular margins. Roughly it was 12 into 10 centimeters, and liver could not be palpated separately from this mass. And CNS examination, child was conscious, power and tone were normal, details were normal, and the plantars were flexors. RS, child had tachypnea with bilateral vesicular breath sounds were heard with bilateral crepitations. CVS, child had tachycardia, H1, H2 were normal, and no murmurs were heard. So based on the history and the examination, our provisional diagnosis was child was having the primary immunodeficiency, IMD 30, and chronic bloody diarrhea, might be due to the query inflammatory bowel disease and query tuberculosis, severe anemia, chronic malnutrition, sepsis, pneumonia, and oral candidiasis. So, course in the hospital. On the day 1, at the time of admission, investigations were sent which revealed severe anemia, HB of 3.3 with leukocytosis and severe thrombocytopenia. Platelet count was 9,000 with DCT was negative. Coagulation profile, INR was 1.8 and raised CRP, which was 203. Serum sodium was 123, potassium was 1.8, calcium was 5.9 and ionic calcium was 0.7. Serum albumin was 1.2 with hypovitaminosis 1.3 nanogram per deciliter. And the stool routine also showed occasional pus cells, plenty of budding yeast cells, and alkali blood was also present. Blood culture was sent at the time of admission. This was the X-ray at the time of admission, which showed the parenchymal lesion in the right lower zone. On the day 1, child was initially managed with the correction of the fluid and electrolytes. packet red cell transfusion was given, platelet transfusion was given, and the antibiotics meropenem was started, and fluconazole was started for the oral thrush. Albumin transfusion was also given. Sputum and gastric aspirate for CVNAT were sent, and at the time of admission, USG abdomen showed small bowel loops, show gross thickening of and hyperechoic foci, suggestive of inflammatory bowel disease. Mesentery is thick, inflamed, and hyperemic. Liver and spleen showed infiltrates. CT abdomen was planned. On the day 2, sputum and gastric aspirate for CVNAT came negative, but on reviewing the NGS report of the immunodeficiency 30, it was found that she had the mutation of IL-12 RB1 gene, which was suggestive of Mendelian susceptibility for mycobacterial diseases. Considering the non-responsive to steroid in this cell for the presumed inflammatory bowel disease and the cervical cold abscess and intestinal stricture, though the mycobacterial infection could not be confirmed microbiologically, considering the possibility of disseminated tuberculosis, AKT was started. This was the NGS report, which was showing the immunodeficiency 30, which was autosomal recessive in inheritance. So the admission blood culture view, Salmonella typhi, which was sensitive to ceftriaxone, piperacillin tazobactam, amoxicillin clavulanic acid, meropenem, and cholesterol. Upon the starting of meropenem, fever subsided on the day 8th of admission. Child continued to have bloody diarrhea. This was the CT abdomen and the pelvis of the child. There was evidence of circumstantial wall thickening with wall edema noted involving the rectosigmoid cecum and transverse colon. High placed cecum and ileocecal junction was noted. In the CT, we can see the thickened walls of the colon and edema. Gastroenterology consultation was taken and was advised for the repeat rectal biopsy and sigmoidoscopy. So sigmoidoscopy showed large perianal fistulous tract with which was an intersphincteric, unhealthy sloughed out mucosa with pseudopolyposis suggestive of pyrrhic Crohn's disease. Colonic biopsy shows the signs of chronic active colitis with moderate grade of activity and no evidence of dysplasia or CMV. Evidence of transmural involvement by Crohn's disease cannot be assessed as it was a mucosal biopsy. On day 35th of the admission, child developed increased abdominal distension and constipation. X-ray erect abdomen was suggestive of intestinal obstruction. So pediatric surgery consultation was taken and the child underwent the emergency loop ileostomy with colonic biopsy. Intraoperative findings at the time of operation was small bowel dilated with mid-jejunum, cecum pulled up towards the right hypochondrium, dilated Raj bowel, intramural thickness was around 3 centimeters, and multiple peritoneal seeding was noted, which were taken for biopsy. Loop ileostomy was done using terminal ileum. So biopsy from the thickened ileum showed acute non-specific inflammation. There was no evidence of granuloma or fungal hyphae or malignancy or CMV inclusion. The meropenem antibiotic was given for 14 days and stopped. Child remained febrile for 12 days, then started having fever again. So around the day 44th of the admission. So repeat blood culture was sent, which again grew Salmonella typhi with same sensitivity pattern, suggestive of persistent Salmonella infection, which is again a feature of IMD 30. So child was started on injection piperacillin tazobactam. After the ileostomy, lower GI bleeding stopped. Child started passing stools from the ileostomy site and abdominal distension was also subsided. Child was restarted on liquids and gradually taken on the oral solid diet. There was slight improvement in the nutritional status. Child was discharged on request on AKT, Cepran prophylaxis, fluconazole prophylaxis and tablets cefixime for 4 weeks in view of persistent salmonellosis. The plan of the patient was there is a possibility of coexisting inflammatory bowel disease with tuberculosis. Also, IPD did not show any improvement to steroid and mesalamine in this case. And the next line of treatment was to start the child on biologics, which could not be started because the TB could not be ruled out in this. So plan was to continue the AKT for 3 months and look for improvement, and then plan laparotomy and colonectomy. Right now the child is under follow-up. Coming to the final diagnosis, it is a case of primary immunodeficiency, IMD 30, Mendelian susceptibility to mycobacterial diseases, inflammatory bowel disease with possible disseminated tuberculosis, persistent salmonellosis, chronic malnutrition with severe growth failure, oral candidiasis, and severe anemia.
Thank you, Rakesh. Good evening, everyone. Now, coming to the dilemmas we faced during treatment. The first dilemma that we faced was whether the child had tuberculosis or inflammatory bowel disease, or whether there was a coexistence of both. Also, due to the severe intestinal involvement, full thickness biopsy could not be taken. Child also had persistent salmonellosis infection. Biologics could not be given for the inflammatory bowel disease as tuberculosis could not be ruled out, and nutritional rehabilitation was another challenge that we faced. Now, what is immunodeficiency 30? Immunodeficiency 30 is caused by homozygous and compound heterozygous mutation in the interleukin receptor beta 1 gene on chromosome 19 short arm loci 13. It is an autosomal recessive inheritance and it's a rare disorder with about 170 cases reported worldwide. Interleukin 12 is an important regulator of host immunity and is primarily secreted by the antigen presenting cell. In short, to see about the function of interleukin 12, as we can see that there is an interleukin 12 which will bind to its high affinity receptor, that is the interleukin 12 receptor beta 1, which is expressed on activated T cells, NK cells and dendritic cells. This will activate the tyrosine kinase 2 pathway, the JAK2 pathway and the STAT pathways, which produces interferon gamma, causing proliferation and increasing cytotoxic potential. Interleukin 12 also induces the CD4 plus T cells to differentiate into T helper 1 cells. What are the associations with immunodeficiency type 30? Immunodeficiency type 30 is the most common form of Mendelian susceptibility to mycobacterial disease. BCG disease and salmonellosis are the most frequent infections associated. Salmonellosis is present in about half of the interleukin 12 receptor beta 1 deficient patients, which was also present in our patient. Severe tuberculosis has been reported in several patients. Mendelian susceptibility to mycobacterial disease or MSMD is characterized by infections with weakly virulent mycobacteria, that is BCG and environmental mycobacteria, also Mycobacterium tuberculosis, Salmonella and Candida, and some intracellular microorganisms. There are 9 genetic defects that have been identified to cause MSMD, and interleukin 12 receptor beta 1 deficiency is the most common form. Interleukin 12 receptor beta 1 deficiency is related to impaired interleukin 12 dependent interferon gamma production, which is a result of defective interleukin 12 receptor signaling. Children with impaired interferon gamma production can be treated by antibiotics and recombinant human interferon gamma, while those suffering from complete defects in interferon gamma receptor signaling, hematopoietic stem cell transplantation is the only option. Penetrance and expressivity in interleukin 12 receptor beta 1 deficiency are highly variable, with some patients asymptomatic while others develop severe disseminated BCG or non-tubercular mycobacteria early in life. Variably formed granulomas are typically present in histopathology and frequently have higher number of organisms. Children with inherited disorders of interleukin 12 interferon gamma axis are vulnerable to non-typhoid as well as typhoid salmonella species. This susceptibility is a well-known feature of the syndrome of MSMD. Approximately half of the patients with MSMD have salmonellosis. Aggressive therapy in form of appropriate antibiotics, interferon adjunctive therapy in moderate to severe infections, and hematopoietic stem cell transplant as the last resort. Long-term antibiotics are recommended for prevention of recurrent salmonellosis. Now, coming to a comparison between Crohn's disease and intestinal tuberculosis, which was one of the dilemmas that we discussed previously. As we know that Crohn's is comparatively has a longer duration of the disease with less frequent chances of bloody diarrhea, more perianal disease involvement, and more extraintestinal features. When coming to endoscopic features, Crohn's disease usually has longitudinal colonic and intestinal ulcers. Aphthous ulcers and cobblestoning is the characteristic appearance that we see in Crohn's disease. The intestinal strictures can be long and multiple. The ileocecal valve is usually gaping in these cases, and intestinal fistula is more common. Mesenteric fat proliferation can be characteristically seen during radiographic examinations, and lymph nodes will show non-caseating necrosis. Granulomas in Crohn's disease are usually small, discrete, loose, and non-caseating. Whereas in contrast, intestinal tuberculosis usually has a shorter course of disease, bloody diarrhea is more frequent, and the perianal involvement is comparatively rare. Extraintestinal features are also rare. There are circumferential colonic and intestinal ulcers in intestinal tuberculosis, Aphthous ulcers and cobblestoning is usually absent in such cases. The intestinal strictures that we see in intestinal tuberculosis are usually small. The ileocecal valve is narrow. Mesenteric fat proliferation is usually absent. And the granuloma seen in intestinal tuberculosis is usually large, confluent, and caseated. So in our patient, we have seen features that were representing both these diseases, which is what caused the confusion. Like there was a longer course of illness. She had bloody diarrhea, which is more frequently seen in intestinal tuberculosis. There was extraintestinal manifestations also present. She had small intestinal strictures, and we could not ever identify a granuloma formation in her case. So that is why this posed a dilemma in our decision whether to give AKT or not, and whether to treat it as a disseminated tuberculosis or not. Thank you so much.
I just want one. It's the first case. I also saw this Mendelian susceptibility to, because KEN they're already diagnosed, but probably they didn't get this Mendelian susceptibility to TB. They were, she was going. When she came with big lymph nodes and so cachexic. But we could not get mycobacteria from anywhere. If you say, if you're in immunocompromised, I would have expected to obtain mycobacteria, not a granuloma. I can expect why the granuloma is not there. Maybe because of the decreased immunity, it is not formed. But you would have been expected to get. So many CB nets have been sent here, everywhere, nothing has come positive. Now you may ask me whether the child responded. They were from Ratnagiri, so 60 days they were with us. It was on free bed, full on the house treatment, big bill, everything. Because it's such an interesting case, we kept doing everything. And just yesterday, before the presentation, she again landed up. Believe me, she had stopped the cefixime and she has again started running fever. Today got the call that the blood culture is again growing GNP, which is most probably Salmonella typhi. This is the third time that child's blood culture is growing Salmonella typhi, which is just like the textbook picture that you see this salmonellosis. Now I am confused what to give. I have just put her on ceftriaxone, azithromycin, of course giving antifungal ceftriaxone continuing. Maybe I have to give it for a. We had sent her on oral cefixime for 4 weeks. They had stopped it in between. But I don't know whether this intracellular organism will ever get cleared from this immunodeficient patient. That's the thing. But to my surprise, all the lymph nodes have disappeared. So I am thinking that she's responding to AKT, but I would say in a much slower fashion, not like the rapid response we would have seen in an immunocompetent patient. She doesn't have great weight gain, but I just wanted to, she just came. We were calling and but lymph nodes have gone. So it is possible that she has disseminated. This is very, very rare, which my book says that anybody presenting with BCGosis, we must always think of this diagnosis. We have only heard. This is the first case which I am also seeing that, which has got this MSMT. And typically that Salmonella is also growing from every blood culture. Today morning only, yesterday they came, today only the back they said it is flagging, it is GNP. So it is a third time. We don't see like that, despite antibiotics. Despite the treatment. So we don't know. Now the big problem is whole of her colon is gone. It is so hypertrophy thick. She probably will have a laparotomy. They will just probably bring down the ileum and just anastomose it down somewhere. So we don't know how. But generally what they say, the mycobacterial infection here are low virulent. It could be even the NTMs, or low virulent mycobacteria, which will go on for a long time. So they don't die, succumb like that. And you see the picture of the child up to 4 years, she was very healthy. The second point to take, so even at the age of presenting at 4 years does not rule out primary immunodeficiency. Not that every primary immunodeficiency will manifest within the first year. Kid will die within 1 year. But you can have different varieties and types of immunodeficiency. So till 4 years, very nice chubby child. So generally what happens when they don't present very early, we don't keep the possibility of immunodeficiency, but you should always keep it can present. Right now with us, we have 4 immunodeficiencies. We have one CGD, we have one IMD, we have one another TTP, we had another 4 immunodeficiencies. All had very, 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 stormy course and multiple diseases. So I'm thankful that we have the lab support that we can extensively investigate. And I think NGS has changed the way in which we look at diseases, but NGS can be very confusing. Sometimes you just don't know what that says, that variant, and how to interpret. And always you must know, genotype always will not correlate with the phenotype. So we have to always say how much of matching is there. Not that exactly what the gene says, everything will be seen in the thing. So that matching between genotype and phenotype. So we opened and we saw many things were matching in this day. Salmonellosis was matching, that disseminated infection was matching, but I could not prove anything microbiologically. So I thought it's a very challenging case, multiple specialists were involved. Thank you.
Thank you, Rakesh and Niharika, for presenting this case. I would like to thank Sarah Dunade Madam for bringing this case for presentation. So I recollect my residency days when there were such interesting cases filled all around, and there are still many cases with Madam that we can have for next presentation. So with this, we move on with the next case presentation, which will be by our own Dr. Vinayak Patki sir. Patki sir is Executive Board Member for Central IAP, as well as he is Head and Director of Department of Pediatrics at Ushakal Institute of Medical Sciences. Over to you, sir.
Thank you, Harshal, for giving me the again opportunity here. This case has been already discussed on live, but I think many people may have missed, and I told him that this will be the repetition for those who have seen. But let's see, just maybe because of PGs, and this not maybe a diagnostic dilemma, there are a lot of issues in this case to as far as how to take decisions, and this exactly happens and just wait. So this case was 42 days baby, just it was second of twin. Was admitted in private hospital for cough cold for and then breathlessness for 2 days. Referred for having recurrent episodes of apnea. Those episodes were related to the cough. That means baby used to cough and then used to get apnea. Was born preterm 36 weeks, seizure, mild RDS, received NSU care, uneventful recovery. Alright for 4 weeks, received basic first immunization. Weight at discharge was 2.5. From 2.3 to 2.5, babies gained weight. Arrival tachypneic 60-66, intercostal subcostal recession 86 to 88 without O2, 177 heart rate, tachycardia was there. Pupils, bilateral cramps and bronchi. Basically, child was quite coughing, and also chest signs, to be very frank, could not be much ascertain. No murmur was there. CNS AF, because we were expecting two things here, because child was apneic and all. So clinical wise there was pulsatile AF, but child was dull, cry activity was dull. This was the presentation. If you see this X-ray, this is reticular pattern is there on both sides. You can see here this air bronchogram, you can able to. And this is a classical reticular pattern with air trapping is there. So suggestive of bilateral sticky opacity, suggestive of viral pneumonia. pH, this was EBG done at admission, but it's okay. PCO2, PO2 of 61 was acceptable. Glucose, sugars, sodium, potassium, everything was okay. Lactate was fine. So problem set, this was NICU graduate, acute respiratory infection, hypoxemia, and recurrent apnea. So basic statement, monosafe amikacin fluid was started, nebulization was started, HFNC, 5 liter flow, FiO2 of 30. Day 2, repeated apnea with now saturation. SpO2 was now going up to 60 on HFNC. No episodes of bradycardia with associated with there, and hemoglobin procal was negative, CRP was borderline 40, mild leukopenia was there. So now the problem was whether to intubate this child, ventilate, any additional treatment is required.
Go to the CBC, please.
And any further investigations.
Vinay, can you go to the CBC, please?
So what you would have done?
CBC, please, Vinay. CBC, sir.
So how you would have approached? Just maybe discussion, nothing much great, because as we
CBC,
go,
full CBC. polymorphs.
Insulin, nothing much was there. Not maybe for 64% of lymphocytes, 44.
Could you ventilate it?
Yes. So, so let's see this. This was a dilemma too because getting recurrent apneas on HFNC. So baby was intubated. Baby was put on PCSE 25 FiO2. They were requiring very less, 18 by 730, and we did cranial USG. This was bedside done by us, so not from radiologist, but more or less same findings were there. Both ventricles were dilated. There was right periventricular leukomalacia, grade 2. On left side there was maybe hemorrhage, but radiologist said we cannot able to differentiate that because it is quite mild and these findings are not correlating with the clinical findings. That's what. So it was aminophylline was added, fentanyl and levetiracetam was given. Though it was not a obvious seizure and BB was started on feeds. This was the X-ray after intubation. Nothing much significant changes had happened. This was on day 2. Day 3 ventilator report supports same tachypnea. But here also few episodes of intermittent desaturation used to get. Same ventilator setting. Now day 3 liver started increasing. Any guess why things are happening? Any pages? What is this? Is now something as NICU graduate, intermittent desaturation, pneumonia, liver size is now increasing. Any additional investigation? Bedside, you want to do anything? Echo, yes. So it is like predicted. So RA-RV dilated, moderate TR, moderate pH, normal LV. Because mild diastolic dysfunction was there, not much systolic dysfunction. IVC was collapsible. So here just to support, we have given dobutamine drip and Lasix was started. Day 6, GC better, no desaturation, was shifted to SIMB. Tachypnea decreased. So here pH was 7.37. This was APG. PCO2 was 74 with FiO2 of only 0.3. Lactate was 1.2. Sodium, potassium, chloride, so normal. Baby was on 10 cc fluids. Meanwhile, so actually came early. I'm showing it later. This is RSV. This was COVID influenza panel sent from, not from tracheal, this was sent from throat. So RSV was proven, which was correlating all this. Whatever desaturation and liver size, what kind of myocarditis kind of picture was there. So that was taken, supportive management in was. So now it is a proven RSV with myocardial dysfunction, convulsive apnea, desaturation. How we should proceed?
You had an EEG. How did you say convulsive apnea?
That's what we have to put convulsive apnea because we are not here also we are not sure whether it is a post cough post apnea or whether it is a convulsive apnea. Though baby was started on levetiracetam here. Anything want to do in this case now? Yes. CSF was done. Protein 36 processed immediately. No cells. Glucose, sugar, everything was normal. Lactate was normal here. Again, urea create okay. Sodium, potassium okay. CRP was 16 from 14. So again, nothing much we could able to help from this. Day 7. Ventilator support ACPC. Now he has developed patch here. This is the right middle zone patch. But child was comfortable. He was saturation of on 18 by 5, FiO2 of 20.25. Child was quite comfortable. Shifted to pressure support mode. Whether you will extubate this child or not. This was just before morning round they have taken X-ray. With the right middle zone dizziness, child is comfortable. Whether you will extubate or not. Will you give extubation trial to this child? Which is senior residents. Because this is your daily dilemma. On town before consultant time you have to make plan how you are going to do. This was RSV proven pneumonia, maybe some convulsions, cranial USG has not shown much things, CSF was normal, biochemistry, electrolytes, sensorium was okay. He was on without any inotropes, without any. So what are the criteria for extubation? Criteria for extubation are, it should be primarily disease free, no inotropes, and should not have any under any sedation. You can, and on pressure support mode, if you are generating good tidal volume, and no tachypnea with minimum pressure support, child is ready for extubate. But with this RN right middle zone, you are always querying whether I am dealing something different. So I have taken decision of extubating this child. Just I will see how these things proceed. Now baby extubated, so switch to piperacillin tazobactam 15 cc 3 hourly, because considering the tracheal aspirate was sent, just considering that this is a hospital acquired pneumonia, he has developed that patch, that may be the reason. Or otherwise can be a RSV also manifestation like that, because
the only thing for back is FIR2 did not work.
yes, so it is not a VAP. So that is very clear. Madam has pointed out it. So it is not a VAP. So FIO2 requirement has not gone. So I extubated this child in thinking of this is RFC pneumonia causing mucus plucking, and because other factors are not correlating, though to give benefit of that pneumonia to the patient, we have shifted this patient and we are starting 15 cc 3 hourly feeds.
Was pertussis checked on this baby with the PCRs?
PCRs were not detected. Whatever detected are there, we have put.
No, but was it checked?
That only positive report.
Because we didn't see the pertussis thing.
Not given.
Not
We are not saying tracheal. We'll come to it
He
later.
was only 42 days.
42 days. 42 days. Yes. So 25-30 cc 3 hourly tachypnea, chest signs have decreased now day 9. Day 10 shifted to 2-3 liters nasal proms, 10 ml sport feeds. Now here the CBC is showing, as Shankar was interested, total count is now increasing. From 4,000 tests come to 11,000. Platelets 7,69,000. How much you will give importance to these rising platelets?
It's important. Thrombocytosis.
So thrombocytosis is also equally important as thrombocytopenia. It suggests something is going on, and CRP is now rising. Antimicrobial susceptibility as blood culture, as we have shown, it has come CLIPSIL. Now see, just I am saying 3 now reports, 3 different reports. Just concentrate on the susceptibility, and you tell me what antibiotics we should have shifted. So he is sensitive to, this is MDR Klebsiella, sensitive to doxycycline, sensitive to fosfomycin, sensitive to tigecycline. Tigecycline MIC is only 1. So whether we should shift to this susceptibility report, we should treat this, or whether we should continue whatever was there here.
How was the clinical improvement?
Just clinically was okay, tolerating feeds.
And he was on meropenem. Yeah.
Here he was on piperacillin tazobactam. Another report came on same day. This is tracheal aspirate. Tracheal aspirate has grown Stenotrophomonas maltophilia. See at colony count 10⁴. And now sensitivity is totally different. Ceftazidime, tazobactam, chloramphenicol, minocycline, and ticagrelor. Now you have 2 different organisms from 2 different sites, whom to treat or which report should be kept aside.
Blood pressure only.
Okay, blood culture, tracheal aspirate, right lower zone pneumonia is, right middle zone pneumonia is there. You are taken just before extubation this thing. Now this thing, colony count, this very very important thing is a colony count from tracheal aspirate should be more than 10⁴. So 10⁴ you have to take with pinch of salt, because the organism is quite dreadful. If you don't act wisely, he is going to kill the patient, because Stenotrophomonas is quite bad because it's a MDR things. Different organism from 2 different samples, selecting antibiotic was a problem. Day 11. So what we did, only we had tigecycline. We have neglected the report of, or just kept aside the report of tracheal aspirate. Day 11, baby maintaining vital spoon feeds, tigecycline was added. Day 12, again 1 episode of now conversion. Tonic posturing, heart rate went up to 230. Whether you would have intubated at this stage or not. Reintubation?
Absolutely tachycardic and saturations are falling here.
Did he settle with that?
Yeah, he settled with
He
that.
settled then only.
He settled with levopilia and 1 dose of phenobarbital. Now again we thinking ki why this child is getting convulsions. even if after now treatment of proper antibiotics. And now this is, so we re-investigated him for conversion, like say calcium, phosphorus, alkaline phosphatase, magnesium, everything was done, lactate was okay, ABG was okay, so not an issue. So now here is MDR CLEP under treatment, a new episode of seizure. What you should do. CSF is done 2 days back. How will you proceed? 2 dreaded organisms we have seen. Now this is, we could able to escape the ventilation in this child. Any investigation you want to say for this child? Now see the days. Day 12 in the hospital. Already on tigecycline and so. Yes?
CSF was normal.
CSF was normal. Yes? Hemorrhage. Okay. Granulation was done twice, repeated. So that's not an issue. Because to get to IVH and all this, child would have become no symptoms. So that's MRI. Yes. So MRI came something different. So you can see here, there are 2 important things are here. One is this spacing. It can be here and see the ventricles. And there is some kind of opacity there at left frontal horn. But this was plain axial. This was T1 with the contrast. This was T1 FS. Then this is T2 axial. And what they reported as contrast enhancement involving sulci bilateral cerebral hemisphere suggestive of meningitis. So, but this was a radiological diagnosis. So, how much to believe in this report is again a questionable issue. Now, there are additional problems. So, child was okay for some while, is now deteriorating. CSF was normal, biochemistry was normal. We are dealing with one Klebsiella. We are dealing with some stenotrophomonas. MRI now has come meningitis. Focal intraparenchymal hemorrhage and Binance. So we are not sure this is not a this involvement is not any collection of symptoms like what we see about subdural empyema or something like that was there. So it was very good. Now third thing. Now CSF culture has come. CSF culture has come. Sphingomonas possibilis. This is a real thing.
Zoo of organisms.
Now see the susceptibility. It is susceptible for so many good things. Amikacin, ampicillin, cefixime, so many things. Minocycline, meropenem. But see, meropenem MS is only 0.1. So which antibiotic you will choose now? Whether you will stop tigecycline, one thing. Whether you will stop tigecycline, add something, or whether you will shift one of this. Because choosing right antibiotic from this is going to save the patient. Otherwise, it is going to create a problem. Yes, please. Anybody? Because this was a real challenge for us to bring out this. The Sphingomonas is growing is something that is not a contamination. No? The Sphingomonas going from CSF is real Sphingomonas. That is very rare kind of this kind of organisms. So their names also very very funny to listen and funny to because these are not routinely we encounter these things. So what you would have done? See, whenever you treat CSF report like this, what you have to choose is any antibiotic which has got good CSF penetration. They always say that whenever you have CSF, that means suggestive of this kind of thing, your penetration is quite good. That means your non-penetrating routine antibiotics, inflamed meningitis can have good penetration. But how much the value they create, the level they create in the CSF is sure. So what you would have, any one answer just before proceeding. Meropenem and minocycline. There are two things I also suspect. That means
minocycline penetration.
Minocycline penetration is okay. Inflamed. So day 14. Now child is becoming done. PhD was taking 15 cc 3 hourly, but most of the times child is to be done. So here I have chosen meropenem. Mannitol 1 dose was given. CRP is now rising. Now from 7,69,000, platelet is dropping to 1,55,000, and total count is rising from 10,000 to 27,000.
Full-blown hospital-acquired infection and meningitis.
So you can't call CSF as a this CSF whatever is there is hospital acquired. Yes, Stenotrophomonas. Yes.
Klebsiella is hospital-acquired.
Yes.
Came with RSV pneumonia.
Yes, yes.
On top of it, he
Yes.
got it.
So that up to that thing it is acceptable, but I will not call it as a VAP. Whatever CSF has grown, you have to take with pinch of salt whether two CSF reports were normal. This has grown something, and now child is slowly becoming deteriorating sensory impairment. Now parents also started questioning what you are doing. But day 14 you are telling some day 3 every time you are selling us some different organisms. You are different antibiotics you are writing. Antibiotic prescriptions is going high. And now he is on tigecycline plus mero. These two antibiotics he was on. So anything you want to change at this stage? Anything you want to do at this stage?
Electrolytes.
Electrolytes were normal. Electrolytes normal, all other investigations. So rising inflammatory markers are how much?
You
See,
do a Procal.
Procal was there. Procal first. Team was there. It was come 1.5. So always we have been told that we have to treat patient and not the report. But here we have to treat both. We have to treat patient also, and so what you would have done at this stage? Any antibiotic change, any new investigation? Because day 15 was really challenging for me at this stage. Because clinically, laboratory wise, everything child was deteriorating. Day 15, vital stable, weak cry, dull activity, BBG was okay. Day 16, platelets better, CRP rising, 78. This is third day of therapy. We are given as per good MIC, that means choice was okay. Anything change? You want to continue or just counsel the parents? Here counseling was a more difficult job because you were knowing the diagnosis, you were knowing the organisms, you were the treating, and that means clinically now everything is fine, but you cannot able to explain why this child is deteriorating. Day 17, 18, good news was baby started crying better, taking feeds well. So we are not changed anything, we are just continuing. Day 19, oral feeds. CRP started dropping now, 32,000. Platelet becoming normal. WBC 12,200. Hemoglobin was okay. 22, day 20, accepting feeds. Breastfeed shifted to mother. Day 21, everything was normal except for platelet. Again, platelet rising. CRP is normal. Patient is discharged. So few things before going to the next part of discussion here is whatever you choose, you have to choose very wisely and when you should be sure what you are treating. That means there is no point in because baby is dull now changing to something else. Markers and all that, it always take in meningitis, always take time to respond to that antibiotic. So if at 72 that was day 15, day 16 was a big question for me to whether to change or not. But just
there was not much option to change it.
Yes, there was nothing as madam is really point. Tigecycline plus meropenem, about that we cannot able to go also. And then we started finding the literature. So this was a BMC infectious disease review. A systemic review of cases of meningitis in the absence of cerebrospinal fluid pyocytosis or pneumonia. So this is not a rare thing. This is from British Medical Journal in 2019. And what he says, they have chased 124 cases from 64 articles. 64 articles. Outcome of 86 cases they have reported. So meningitis is the absence of pleocytosis on CSF is extremely rare. If this occurs, causative organism is likely to be more bacterial, not viral. And this was the subgroup analysis what they have put. This is age, gender, pathogen, comorbidity and outcome. You go on seeing neonates and pediatric. Pediatric is the most common. Then neonate and adults. And if you see bacterial are 46% and see the outcome. So mortality is quite low. It's only, that means 16%, and mortality is quite high in adults, 39%. Now this coming to spingomonas possibility. It's a rare infectious disease found in cerebrospinal. This is under publication. So let's see whether they, because there are a lot of things which cannot be explained on why, whether it is a really, he has got this thing, why we could not able to do CSF, we could not able to get this thing. And this is a gram negative.
Why it did not grow from blood?
Blood. This is
If it had matched with blood, it would have
we should have been more
relevance.
yes, it has existed in usually soil, drinking water. After this, we checked all our water sources. Unfortunately, it was given task to the microbials, but we could not able to. That means it was gained from the community, not from our sources. And if you see the course now, retrospectively, he has been treated with some organism. If you see the last list, one of organism he has piperacillin, tazobactam, some sensitivity was there, and all that it was just going on. So it was like a partially treated, but CSF pleocytosis was not there at all. So that was more confusing. Both nosocomial as well as, and community acquired infections are also reported from, because this was a preterm baby and also likely to have some underlying relative immunodeficiency, and that may have caused. Now third is Stenotrophomonas malphilae. This is unique emerging pathogen. So this is actually a common cell, basically a common cell emerging as a pathogen, earlier noted as a broad spectrum life-threatening infections among vultures. More recently, it is a pathogen in a immunocompetent cold, and this is coming a big danger.
Water and aerosol.
Yes, this is a big danger for our ICUs. After this, I discussed at least 8 to 10 corporate hospitals of India, and they say that now you should have given more importance to the Stenotrophomonas. But I have not given because the colony count was less.
And from trachea.
Trachea, and it was a trachea response. So otherwise, if would have gone this colony count was more than 2, 10:5, 10:6, definitely it would have been big headache for us. So this is something which, that means you can come across in ICU this kind of infection, because now availability of molecular diagnosis, or you can say culture facilities are available. You can get these things easily and all that, but sometimes it confuses also. And you can come across a situation where things, that means whatever thing you are treating is really rare. That means our always impression in the mind is CSF. Whenever we call meningitis, we always think about some pleocytosis, unless and it is a very like immunosuppressive drugs and all that, where there is hardly any response. And I always check, as madam student, I always check, and I send resident till now to go and see the lab, and 15 days I want, because we used to go on this to get the CSF report. The same culture I have followed there. So within 15 minutes they come, and I have trained pathologists also. Once we send somebody, our fellows also, they have to check that. So they were also surprised ki without CSF pleocytosis means this meropenem, remember this was given for 6 weeks. The child is coming regular follow-up now.
No hydrocephalus.
No hydrocephalus, milestones are normal. And he's doing well. So he was a twin. So other child was also suffering similar episode. That has also grown RSV. But fortunately he has not gone in that stage, and within 5th or 6th day we could able to send this child. So here also meropenem, how many days to give is again a big issue. You have to give, as meropenem says, ki this is, if this kind of organisms are there, you have to give as long as possible, 4 to 6 weeks.
Second thing, again check the immunity of this child.
Yes.
And this viral infections can many times precipitate these things. It can start like one RSV, adeno, then they go on to become very bad bacterial infection. And this very less pleocytosis, pneumococcal meningitis also sometimes.
Now they have that all those CSF markers. So that came negative. Surprisingly, that was not something for PGs and all of us to have. You can come across some rare cases where our age-old teaching, because only 124 cases till 2019. Many may not have been published also. And this was quite a combination of this. I think makes these things interesting. Thank you for the opportunity.
Thank you, sir. this case was presented by Sir on Casebook Live episode of Maha IAP. It also had a very big response, and I still remember after finishing the IAP meeting that night, we went back, and afterwards I had seen that episode where Uday Rajput sir was also a part of it as a moderator, if I'm not wrong. So with this, I would like to thank Patki sir for such an excellent presentation. Moving ahead with the felicitation program. First of all, felicitation of the presenters. I would like to request Amnapure sir to come ahead to felicitate the presenters of first case, Dr. Rakesh, Dr. Niharika, and their mentor, Dr. Dhanode madam.
We felicitate them. Give them a clap for the. I think they presented quite
Very
nicely. Nice presentation.
I would now request Dr. Wag sir to come ahead and to felicitate Dr. Patki sir.
Integral part.
I would request Santosh Kulkarni sir to come ahead and to felicitate our sponsors for tonight, Team Mankind, for helping us at last moment, Star Division of Mankind. Please go. Now for a special felicitation. So last month we established Women's Wing of IAP, and the first awareness video, which was on autism, was also appreciated, which was made by them. So today we announce our Secretary of Women's Wing, Dr. Shabana Mujawar madam, and I would request Dr. Dhanode madam to come ahead to felicitate Dr. Shabana Mujawar madam. Dr. Shabana Mujawar madam will be now the Secretary Women's Wing of IAP Sangli District Branch. With this, I would request the office bearers of IAP Sangli District Branch to come ahead, Dr. Matin sir, Dr. Wag sir, and Dr. Jeevan Mani sir to come ahead along with Shabana madam for a photograph. And along with them, our backbone, that is Executive Board Member of Central IAP, Dr. Vinayak Patri sir, also to come ahead with us. So this meeting has been broadcasted live on YouTube, and the broadcast will be available, and the link will be sent on the IAP group. So dinner is ready and everyone can join in for dinner. Thank you.
चालेल ना नाही 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 काही गरज नाही त्यांना फक्त फोटो पाहिजे कारण हे बिल त्याशिवाय पास होत नाही.